starting with hypofractionation, and I touched on it in the symposium yesterday. So why did hypofractionation start in the United Kingdom and Canada? America was very much late, but hypofractionation became a standard of treatment in the UK and Canada. It's very simple. It's cost, it's money, because hypofractionation will cost less, and also the type of health care in the United Kingdom and Canada is like governmental health care, and people just wait their turn. I mean, in Canada, women used to wait 4, 5, 6, and 8 weeks from surgery to start the radiation, even sometimes 12 weeks, just waiting because of the system. And then that's why they started to say 6 weeks of radiation is too long. If we find out a shorter course of radiation, the turnaround will be quickly, the cost will be less. Those are the main reasons. So it's cost, and convenience, and then shorter wait time, whether it's more effective and less toxic. That's what the trials showed. So starting with the Canadian trial, a little bit old, 93 to 96. So this was pre-sentinel lymph node era. It was hypofractionation and acceleration. Hypofractionation means high dose per fraction. Acceleration means shorter than 6 weeks of radiation. Very simple design, 50 gray in 2 gray per fraction. The caveat with this trial is that it did not allow any boost, and compared to 42.5 in 16 fraction. So that's 5 weeks versus 3 weeks and a day. So it's a discount of 2 weeks. And as we know, it gave exactly the same result. Everything was superimposed. Survival, disease-free survival, toxicity, clinical outcome, local failure rate was the same. So this really established the fact that you could go down in the radiation course from 6 weeks or 5 weeks into 3 weeks. And the follow-up was 12 years. Now the British, they had a couple of large trials. This one is the one which they used, again, hypofractionation and acceleration. Very impressive number of patients, 2,200 accrued in only 2 years. And they included T1 to T3 and 0. And they compared, again, 5 weeks of radiation as a standard, as a control, versus 40 gray in 15 fractions in 3 weeks. A little bit different than the Canadian, which had 42, this one had 40. But again, 5 weeks versus 3 weeks, they allowed the boost. They did not mandate it, and this is one of the differences. The Canadian did not allow a boost. And they showed that it is similar in local relapse, although a little bit better in the 3 weeks, so nobody expected that. The main endpoint of these trials is non-inferiority. So they wanted just to show that we will give you the same results, but go down in overall treatment time. And the interesting thing is that disease-free survival was better with the hypofractionation, and the cosmetic results, the complications, were actually better with the hypofractionation in terms of breast shrinkage, breast induration, and other factors. And when you put the three together, so you will find that the local failure rate of the Canadian Start A and Start B was really very, very acceptable, much lower in the British, because they allowed boost, and they had more than 50% of the patients who had boost. It was at the discretion of the treating physician, and here they did not allow boost. The local control is good, disease-free survival is good, clinical outcome, cosmetic results is good, so why don't we shift into 3 weeks? It will be more convenient to a lot of women and less costly. The US, it took time to understand that, unfortunately, but they approached this issue in a different way. They allowed people to go into the Canadian or the British hypofractionation, but the boost issue was a problem, because the EORTC showed a significant increase in local control by using a boost, while the Canadian did not use a boost, the British half-half. So they designed a randomized trial which completed accrual using a concomitant boost, which means you give the radiation to the whole breast. From the first day, you start right away by giving the boost. You add a little bit of dose. And they used IMRT as a sophisticated technique, and this, of course, will not bring the cost down. So that's the design. It's an RTOG trial which completed accrual and still not published yet, still not analyzed yet. And the good thing about this is that they included high-risk patients, because the Canadian included low-risk patients. Now, can we use the Canadian fractionation on high-risk patients? It's going to be an extrapolation, but it was not in the trial. So here they included women with node negative, with LVI, triple negative, oncotype more than 25, etc. Standard was 6 weeks of radiation, 5 weeks of whole breast followed by a boost as a standard of treatment, like everybody or most people do. The hypofractionation was whole breast irradiation concomitant with a boost.